Thank you. That was a great introduction. So really bridges what I did. Is that really bridges what I did in my master's with what I'm doing now in my PhD, which is to develop a novel method for the isolation specifically of human endometrial cells from menstrual blood and use those in the endeavor to understand the pathophysiology of heavy menstrual bleeding in von Willebrand's disease. So, just a quick overview of menstruation. As many of you are aware, menstruation involves shedding of the superficial lining of the uterus, known as the endometrium. And importantly, the endometrium itself is made up of two layers. So, first, there's the basal layer or the basalis, and this is the thin layer that sits adjacent to the myometrium, and it remains intact throughout the entire menstrual cycle. And then we have the functional layer or the functionalis, which is the thicker innermost mucosal layer. And when it's fully intact, it consists of a dense stroma rich in fibroblasts and immune cells, and it is highly vascularized by these spiral arteries. And this functionalis is the part that is shed and regenerated over the course of one menstrual cycle, as all cells in the functionalis, be they stromal cells or vascular cells, are highly sensitive to shifting hormone levels. So the average menstrual cycle takes place over the course of around 28 to 30 days and includes 3 phases, with menstruation being the first, followed then by the proliferative and the secretory phase. During the proliferative phase, this is when rising estradiol levels stimulate significant regeneration of that functionalis layer. And then midway through the cycle, ovulation occurs, after which the dominant follicle becomes what is called a corpus luteum and begins to secrete high levels of progesterone. So then that shift in hormone levels is going to promote further morphological changes to the cells in the endometrium, specifically throughout the early and mid-secretory phases. And then by the late secretory phase, if no implantation has occurred, then those hormone levels plummet. And this sharp decline leads to an increase in local inflammatory mediators, as well as blood vessel constriction, tissue breakdown, and subsequent bleeding. So this ushers in the menstrual phase, which normally takes place over the course of around 2 to 7 days, with normal menstrual blood loss around this time being around 30 to 50 milliliters in total. And the cessation of bleeding or endometrial hemostasis is controlled then by a number of local hemostatic and fibrinolytic factors, and then the cycle repeats itself. And just as a brief aside, I want to mention that menstrual blood is a complex mixture, and that the term itself can be a little bit misleading because only about 30 to 50% of the fluid is actually composed of blood. The remainder is made up of materials that are naturally expelled during menstruation, including things like cervical mucus, vaginal secretions, fragments of endometrial tissue that once lined the uterus, and other immune components. So in contrast to normal menstrual bleeding, heavy menstrual bleeding is clinically defined as more than 80 milliliters of blood loss per cycle. However, a broader classification includes excessive menstrual blood loss, which impacts an individual's quality of life. And this is reflected in things like missed school, work, and social obligations for these individuals. Other consequences of heavy menstrual bleeding include iron deficiency with or without anemia, and its associated symptoms of fatigue, lethargy, and exertional dyspnea. And then, of course, if heavy menstrual bleeding is severe, there may also be a need for invasive permanent procedures, which present their own set of risks and are often at the cost of an individual's fertility. So importantly, 1 in 3 menstruating individuals will experience heavy menstrual bleeding at least once in their lifetime. And while this seems like a high percentage of the population, there's still very little known about the pathophysiology of heavy menstrual bleeding. In fact, a specific cause for heavy menstrual bleeding is identified in less than 50% of affected individuals. As such, the International Federation of Gynecology and Obstetrics have developed what is called the Palm-Cohen classification system in order to categorize known causes of abnormal menstrual bleeding, which is a general term that encompasses heavy menstrual bleeding or menorrhagia. And so the PALM group consists of structural abnormalities, which can easily enough be visualized using imaging techniques or diagnosed by histopathology. And then non-structural causes to heavy menstrual bleeding are included in the Cohen group and are much less understood. So the focus of this project will be on coagulopathies, which refer to bleeding disorders where the underlying issue is related to the body's ability to form clots rather than the uterus itself, and also endometrial causes, which refer to functional issues of the endometrium in regards to things like specifically local hemostasis, as well as vessel formation and repair. So von Willebrand disease, or VWD, is the most common inherited bleeding disorder, affecting approximately 1 in 1,000 individuals. And from that, it's important to note that it affects men and women equally. So VWD results from either a quantitative deficiency or qualitative defect in the VWF protein, so the von Willebrand factor protein. And this is a large multimeric clotting protein involved in primary hemostasis, as it facilitates platelet adhesion at sites of injury, and in coagulation, as it acts as a chaperone for clotting factor 8. So symptoms range in severity depending on the type, but frequently include mucocutaneous bleeding such as epistaxis and bleeding from the gums when following dental work, as well as easy bruising, prolonged bleeding from minor wounds, and gastrointestinal bleeding. And in women with VWD, this frequently manifests with heavy menstrual bleeding. In fact, heavy menstrual bleeding is the most common symptom experienced by women with VWD, affecting roughly 74 to 92% of this population. And this often begins right at menarche as the first real clinical manifestation that these individuals encounter. And especially in milder forms of the disease, this may also be the only indication of a bleeding disorder until significant bleeding events occur, such as during surgery, trauma, or of course childbirth, which is also when women with VWD are at increased risk for postpartum hemorrhage. So although there seems to be an intrinsic link between heavy menstrual bleeding and VWD, very little is still known regarding the functional role of VWF in endometrial hemostasis and its role in heavy menstrual bleeding as a whole. After almost 100 years since the discovery of von Willebrand's disease, gaps still exist in our understanding of the disease and one of its most predominant symptoms. So women with bleeding disorders not only face unique challenges in how their symptoms present, but also in how they're diagnosed. So unfortunately, because heavy menstrual bleeding is often normalized, dismissed, treated symptomatically without further investigation, or simply not discussed, many women with bleeding disorders end up going undiagnosed for years. Existing stigmas around menstruation, discomfort discussing menstrual symptoms, and a lack of menstrual health education can all contribute both to mischaracterization of bleeding severity as well as underreporting. And studies have found that the average age that an underlying bleeding disorder is diagnosed in women who report heavy menstrual bleeding is 35 years old. And by that time, many women have already had well over 200 periods over the course of their life. As such, objective, accurate, and accessible methods for assessing menstrual blood loss are essential for early recognition of abnormal gynecological bleeding. Practical tools include the bleeding assessment charts, like the pictorial bleeding assessment chart, or the PBAC, which is a scoring system initially developed and validated for the use with absorbent sanitary products back in 1990. And it allows individuals to basically record the number and saturation level of products used during menstruation. And this then corresponds to a PBAC score, which can be used to estimate total menstrual blood loss over the course of that cycle. Now, moving past symptoms and diagnosis, women with bleeding disorders are also faced with unique challenges when it comes to treatment for heavy menstrual bleeding. Typical medications used in the general treatment include things like non-steroidal anti-inflammatories, as well as antifibrinolytics like tranexamic acid, and hormonal contraceptives. So while tranexamic acid is often effective in treating heavy menstrual bleeding. It's often prescribed before hematologic evaluation or diagnosis. So it still does not identify the underlying cause for the bleeding disorder, for the heavy menstrual bleeding. And the same can be said for hormonal medications like oral contraceptives and IUDs. And then more invasive procedures includes things like endometrial ablation, and then in the most severe cases, of course, hysterectomy. These are, of course, not appropriate for adolescents or women who wish to maintain fertility and are associated with their own sets of risks. And then for treatment of heavy menstrual bleeding in women with von Willebrand's disease, non-hormonal hemostatic agents, including tranexamic acid, as I previously discussed, as well as coagulation factor concentrates and desmopressin are typically used. So with all this in mind, many cases, a combination of both non-hormonal and hormonal medications are required to treat heavy menstrual bleeding, and we currently have no way to predict how patients respond to these treatments. So an enhanced understanding of the underlying pathophysiology of heavy menstrual bleeding is then essential for improving management strategies and identifying targeted treatments for heavy menstrual bleeding. So this then brings me to the next topic, which is models to study this type of pathophysiology. So endothelial cells, or ECs, are the cells that line our blood vessels. They're arranged in a monolayer that interacts on one side with the basement membrane, namely the subendothelial collagen to which they're anchored. And then on the other side, they interact with contents of the lumen. They're capable of modulating vascular tone and blood flow, and they control both hemostasis and fibrinolysis by secreting factors essential for both the formation and dissolution of clots. And they also play a role in the formation of new vessels or angiogenesis through splitting and elongation. So importantly, patient-derived endothelial cells provide a window into individual phenotypes when studied in vitro. Endothelial colony-forming cells, or ECFCs, for example, are isolated from peripheral blood and have been used by our group and others in the study of VWD pathobiology. However, this type of isolation requires about 50 milliliters of peripheral blood for isolation, which isn't ideal for patients already experiencing iron deficiency or anemia. And in addition, the cells may not necessarily represent a specific vascular bed or accurately represent organ-specific bleeding. In contrast to that, endothelial cells isolated from specific vascular beds retain site-specific characteristics and specifically reflect microenvironmental influences. And this makes them a valuable model for personalized approaches for studying diseases. And when it comes specifically to studying heavy menstrual bleeding, HEECs, or human endometrial endothelial cells, are especially relevant. So these cells are, of course, isolated from the endometrium itself and represent the vascular bed directly involved in menstruation. By focusing on this cell type, we can better understand how local vascular function or dysfunction contributes to menstrual blood loss, and how specific hemostatic, fibrinolytic, or angiogenic mechanisms may differ in women with VWD compared to healthy controls. But currently, HEECs are isolated solely from endometrial biopsies or tissue collected during hysterectomies. So these are, of course, both invasive procedures representing their own sets of risks, and are usually also performed when there's already some type of medical issue or condition present. Importantly, this endometrial tissue is also not sampled usually during the menstrual phase itself. And because characteristics and behavior of endometrial cells change so significantly over the course of one menstrual cycle, cells obtained during maybe the proliferative or the secretory phases may not reflect the microenvironment of the uterus during active bleeding. And this means that important menstrual phase specific features, such as altered expression of clotting factors or increased fibrinolytic activity, may be missed. So unlike biopsy samples, menstrual blood is produced naturally and can be non-invasively acquired over the course of multiple cycles. As I previously mentioned, it contains a diverse population of cells that reflect conditions during actual menstruation and contains factors that are specific to this phase. So by isolating HEECs from specifically at menstruation, we can capture a more accurate picture of how the endometrial vasculature behaves at the time of bleeding and better identify why women with VWD are at higher risk from heavy menstrual bleeding. Okay, so with all that being said, this project seeks to understand the influence of local uterine factors on heavy menstrual bleeding using HEECs derived from menstrual blood of patients with VWD compared to healthy controls. And this will be accomplished based on the 4 aims. So of course, number 1 is going to be the big one: develop and optimize a novel method for the isolation of these cells, specifically from menstrual blood. And then next, we will aim to evaluate hemostatic and fibrinolytic factors in VWD patients compared to controls. And then the third will be to evaluate angiogenic behavior and angiogenic potential in HEECs derived from VWD patients compared to controls. And finally, because that PBAC was originally developed for absorbent products that I'd mentioned previously, our aim is to validate a menstrual cup PBAC and see its use as a tool for actually estimating menstrual blood loss with this form of sanitary protection. Okay, so to start with aim 1, which is again to optimize a protocol for isolating these cells from menstrual blood. So unfortunately, I want to start off by saying that isolating these types of cells, and not only just from the endometrium, but other microvascular networks, presents some unique challenges. So even when these cells are isolated from tissue samples, there's a very large diversity of cells in the population of the samples, and endothelial cells specifically often make up a very low percentage of that. Microvascular endothelial cells also have unique nutrient requirements that aren't necessarily the same as larger vessel cells like human umbilical vein endothelial cells. And because of this, contaminating cells like fibroblasts, parasites, and smooth muscle cells can easily overgrow primary cultures as they are more vigorous and divide more rapidly. So in the pursuit of obtaining a pure, viable endothelial cell culture from menstrual blood, I've done a lot of optimization in how menstrual blood samples are collected and initially processed, how menstrual blood cells are then purified and cultured, and I've been exploring how best to characterize this novel cell model and confirm endothelial cell phenotype. So first, let's go over the process of sample collection and that initial processing. So for the optimization process, menstrual blood samples have been collected by healthy participants on days 1 to 3 of menstruation through the use of a Diva cup, which is a brand of menstrual cup which is inserted and collects menstrual blood, not the same as a pad or tampon, which uses absorbency. This menstrual blood is then decanted into a 50 ml conical by the participants themselves, mixed in a 1-to-1 ratio with buffer and stored at 4 degrees until transport to the lab. And then once received by myself, it's filtered as many times as necessary to remove debris. So things like clots, tissue fragments, what have you. And it may also have to be further diluted at this point if there's a large amount of mucus in the samples. And so this has kind of been the standard method I've used throughout the optimization process, only with slight variations in the composition of the buffer and that ratio that I use to dilute the menstrual blood. The goal of this is basically to clean up the samples as much as possible before isolation. And then the first strategy that I use to then try and purify the samples more is, of course, to enrich those endothelial cell populations, which includes density gradient centrifugation. And this is either done with histopac or Percol. Histopac being able to basically remove your red blood cells. And then Percol, you can actually create a density gradient with different densities of the Percol itself. And this will allow you to isolate several specific types of cells in one centrifugation. So I've had some success with this, but it's not my favorite. And then from this population, once these cells have been cleaned up even more, they can be enriched further either by fluorescence activated cell sorting or magnetic activated cell sorting. And so this allows us to obviously obtain a purified population suitable for cultures, and we can either positively select for cells of interest based on their expressed markers, or we can deplete unwanted cells from the population. And so based on preliminary results, this is flow cytometry that I did just on a crude menstrual blood sample. We see that there's relatively high CD90 expression, which is a fibroblast marker. And then we also have CD31 expression as well as UEA1 binding. So these are kind of the markers I've focused on for this portion. And then so once either the fluorescently labeled antibody or the magnetic antibody is conjugated to the cells, they can either be applied to a magnet, which retains the cells of interest, or they can be sorted by flow cytometry based on their fluorescent signal. And through this, we can then culture only those specific cells that are either expressing the marker we're looking for, or the cells that have had unwanted cells, or the cultures that have had other cells depleted from them. And then the next step has kind of been to tweak cell culture conditions, because as I mentioned before, microvascular endothelial cells are a little bit more finicky. They have a bit more specific nutrient requirements. So once they've been purified, they'll be resuspended in a specific culture medium. So from the literature and my own experience, I found that they require a bit higher levels of serum for survival, especially after recovery of that initial purification process. So studies have used anywhere from 10 up to 50% serum in the media. I think 20 is a pretty good amount for me, and nothing more has really increased proliferation at all. And then there's the addition of different growth factors, so VEGF, FGF, EGF, as well as your other components like hydrocortisone, ascorbic acid, and heparin, all of which I've played around with different concentrations to see which one works. And so another thing that's important that I've found is that because endometrial endothelium is highly junctional and barrier dependent, the addition of some type of cyclic AMP booster, I call it, seems to help microvascular endothelial cells proliferate, especially in those earlier phases when they are just recovering from purification and are initially adhering to the substrate. So specifically, I've used this cyclic AMP analog DBCAMP, and I've included a phosphodiesterase inhibitor, IBMX. And so these are both basically added to increase endogenous cyclic AMP levels in these cells. And by doing so, promote an endothelial cell morphology, including things like CD144 or VHEEC adherent expression and their arrangement into that uniform cobblestone morphology. And so as adherent cells, I've also trialed different substrates. As they are adherent cells, I've also trialed different substrates. And these include fibronectin, gelatin, and collagen, all of which are recognized by different integrins expressed by endothelial cells. Based on my own experience, I find that the cells adhere very quickly to fibronectin, so that's kind of what I've continued on with throughout my optimization. And now the next step will be to confirm endothelial cell phenotype in these cells. And again, this presents its own set of challenges because endothelial cells isolated from different vascular beds display different phenotypes. And the lack of a specific marker may not necessarily mean that they are not endothelial. So there's a multiple step approach to phenotyping these cells because of that. So of course, once they're in culture, they're monitored daily by bright field microscope and assessed for colony formation and cell morphology. And we're looking for that classic cobblestone morphology that endothelial cells have. They exhibit contact inhibition, so they're not going to necessarily grow on top of themselves like something like a fibroblast. And a fibroblast is, of course, much more spindle-shaped and elongated and has a disorganized arrangement. We also conducted immunophenotyping by both flow cytometry and focal immunofluorescence microscopy. And these included common markers typically used for endothelial cells, including CD31, CD144, And we also included some different assays that can be assessed by confocals, such as UEA binding and DIL-AC-LDL1 uptake. And then non-endothelial cell markers were also included because this is often a useful step when you don't really know the characterization of the cells you're studying to begin with. It's hard to know what you're looking for. So then by assessing the proportion of other cell types in your samples, it gives you a better idea of what you're working with. And so here are some bright field images of cells I've isolated from one control. The first one's going to be no purification. So after that initial processing step, cells are just plated as is. Second one's going to be the magnetic activated cell sorting. And the third will be fluorescence activated cell sorting. And so you can kind of see based on the reference images what we're looking for and how you can
Just address the light get turned on. Put the light off.
And how you can quickly kind of discern whether you have endothelial cells at all in your cultures. So importantly, no purification hasn't proven to be a good idea because there's obviously too much of an overgrowth of fibroblasts. And then for the fluorescence activated cell sorting, I find that this is still giving me more of a heterogeneous cell population. And also cells have a very low recovery rate after this protocol. So everything going forward, all the cells that I referenced going forward have been isolated using the MAX method, so the magnetic activated cell sorting. And so this is just another example of what I'm looking for. These are more bright field images, and this is from 6 out of 8 of our controls. And so these, again, were not purified, and you can see that they have that whirling conformation that you see in fibroblasts, and they don't exhibit contact inhibition. And this is also kind of mirrored in the confocal images that I just want to show so that you can kind of see how these cells grow when they're obviously overgrown with some type of contaminating cell. And then in contrast to that, these are all the exact same controls, and these are cells isolated from them following purification. So you can see that, if you see like here, for example, we still see evidence of some types of different cell morphologies, but in general, it's a much more uniform, much more well-organized culture. So because of this, again, I'm going forward with the magnetic activated cell sorting for purification. And so over to more so immunophenotyping, looking at the expression of EC-specific markers. So this on the left is data from flow cytometry, just of two separate cells from two separate controls, looking at CD31 and CD144. And then on the right, we have confocal images of CD31 staining. So there's obviously weak expression of both CD31 and 144 in these cells, which are typically commonly used endothelial cell markers. We also, just to note, we had negative staining for CD144 and alpha smooth muscle actin in these cells as well. And then additional immunophenotyping includes the following markers. So we have no expression of CD34, 309, or 133, and then moderate expression of CD5161 or integrin alpha V beta 3, as well as CD146 and that CD90, which again is going to be your fibroblast marker. So from all of this information, it's clear that about like 20% of these specific cultures still have some type of contaminating cell in them. And from this, it just is going to be more optimization in terms of maybe an additional purification step or tweaking some type of culture media component. And so phenotypes of these cells can be further confirmed using functional assays, and that can reflect characteristic endothelial cell binding properties. So an example of this would be the UE1 lectin, which selectively binds to the L-fucose residues expressed highly on the surface of endothelial cells. And this will produce a strong and specific staining pattern when imaged using confocal. And so using HEECs, which is human umbilical vein endothelial cells commercially purchased, they were the positive control for this endothelial cell phenotype. You can see that there was positive UEA binding in cultures for all the both the controls and the patient that were analyzed. And then another complementary assay for phenotype confirmation would be the uptake of acetylated low-density lipoprotein that's been labeled with the fluorescent dye DIL. So essentially, endothelial cells internalize DIL ACLDL through a scavenger receptor pathway, and this uptake can then be visualized by confocal. So again, with HEECs as a positive control, I see evidence of DIL ACLDL uptake in purified cultures from these normal controls. The staining is weaker than I would have expected, but this is comparable to what we see in HEECs, which is the positive control. So this is promising, and it might just mean that this particular assay needs optimization itself. So then when analyzed together, UEA1 binding and DIL ACLDL uptake provide a pretty strong functional validation that culture cells are in fact endothelial. And so you're looking for cells that are obviously positive for both of these characteristics. And this is just on the bottom, the overlay of the red DIL ACLDL uptake and the yellow UEA1 binding. So in summary frame 1, the cells that we've isolated to date show downregulated expression of typical endothelial cell markers, CD31, 144, and 34. And we've got moderate expression of others, including 51, 61, and 146. And those positive functional assays, as well as evidence of some contaminating cell type. So next steps involve immunophenotyping the remaining control cells, as well as implementing additional strategies for phenotype confirmation. So different things like stimulating the expression of ICAM, E-selectin, and VCAM, which will be expressed on the surface of endothelial cells following exposure to things like cytokines like TNF-alpha, and then endothelial nitric oxide synthase is a pretty across-the-board universal endothelial cell marker that can be used. And then additional purification, maybe using a FACS method after the initial max purification. We'll see. And then briefly for AIM2, so AIM2 again is to characterize the hemostatic and fibrinolytic factor expression, storage, and secretion in HEECs derived from menstrual blood. And so we're looking to identify variations in these factors between HEECs isolated from VWD patients and those in normal controls. And so we obviously hypothesize there will be difference in local uterine and hemostatic fibrinolytic factors in HEECs from these patients compared to controls. So getting into the actual meat of the project then, we're looking at, for recruitment, 10 normal controls and 10 patients with VWD. So controls have no known history of bleeding problems, and then VWD patients will have a diagnosis of VWD, and exclusion includes things like unstable use of hormonal medications, pregnancy, and any other things that may actually affect menstrual blood loss or other bleeding patterns. And so menstrual blood will be collected in that same time frame, and we're also hoping to collect peripheral blood within that same time frame in order to compare factor levels in both. And then upon receipt of the samples, we collect menstrual blood or peripheral blood plasma, as well as the menstrual blood supernatant for protein analysis. And a portion of that menstrual blood will also be removed for HEEC isolation. And then when we isolate those HEECs, again, just studying them in culture, we're going to look at both stored proteins, so by lysing the cells and analyzing that, and also secreted proteins, so exposing these cells to different agonists that will stimulate secretion, and then quantifying that in the media. So again, it'll be quantified in the stored lysates, the secreted supernatant, and then also in the peripheral blood plasma and menstrual blood plasma. And so this is just the baseline characteristics of who we have recruited so far. So we have 8 controls and 7 VWD patients. And the mean age between the two is comparable, no significance. But then, of course, as to be expected, the self-BAT score, there is significantly higher bleeding assessment done in the VWD patients. And this is going to be just information for what we have so far. So while we do have 8 controls and 7 VWD patients recruited so far, we have only received samples from our menstrual blood sample from one of those VWD patients, and very few patients have been able to coordinate peripheral blood collection with menstrual blood. And so going into the next task, which will be VWF localization in these cells. So I briefly want to mention that normal endothelial cells derived from large and medium-sized vessels have high expression of VWF, and that it's stored in these rod-shaped organelles called Weibel Pallady bodies. It's pretty easy to identify when you're doing confocal, whereas microvascular endothelial cells, it's much more heterogeneous of expression, and the intercellular staining may be more granule and or completely absent. So with that being said, I wanted to see if these cells even expressed VWF, making them a suitable model for the study of von Willebrand's disease, and if I could localize it to specific organelles. So this is VWF staining done in 4 of the controls, and you can see that while VWF is not expressed in all cells, it definitely is localized to that perinuclear area, and it's much more granular than seen in another cell type like HEECs. So just summary here, we have 8 out of 10 of our normal controls recruited and 7 out of 10 of our VWD patients. And then for menstrual blood samples, we have all menstrual blood for our controls and 1 from our VWD patients. So this will just mean that we have to actually contact our patients to get the samples now that things are going with the optimization. And that next step is exactly what I just mentioned. We're going to expand recruitment and collect samples from these patients now that the optimization phase is moving along nicely, I guess. And then just briefly for aim 3, which is going to be same thing. Nothing's been done for this aim yet, but I'll mention it because it's going to be the quantification of angiogenic factors, the same thing as with aim 2. These will be stored and secreted by HEECs, and it will also be studied in the peripheral blood and menstrual blood of VWD patients compared to controls. And we'll also perform adhesion and proliferation assays on these cells to see if cells from patients with VWD have altered angiogenic potential. And then we, of course, hypothesize then that there will be some kind of dysregulation with the angiogenesis in VWD patients compared to normal controls. And finally, for aim 4, so aim 4 was, again, to that PBAC validation using the menstrual cup and using it to estimate menstrual blood loss over the course of 1 cycle. So patients enrolled in this study also complete many of them will also complete PBACs. So they'll complete these charts for 1 menstrual cycle, 3 months of pad or tampon use, and then 3 months with the menstrual cup. And then we can compare not only PBAC scores, but then the estimated menstrual blood loss between the 2. And this information will be used to identify any correlations between menstrual blood loss and the results from cellular studies in aims 2 and 3. And here's just the brief preliminary results we have from this. So we have this PBAC information from 2 controls and 2 VWD patients. And while PBAC scores and menstrual blood loss are comparable in the controls, regardless of the form of sanitary protection used, you can see that on the right-hand side, when you look at the VWD patients, that there is significantly higher interpretation of menstrual blood loss when these patients use pads or tampons compared to when they use a menstrual cup. So I just want to include this because this is, to me, interesting preliminary information, and we hope to explore this more going forward. And before I wrap up, I want to just discuss the limitations very quickly, because while I tout menstrual blood as this phenomenal sample type that you can isolate cells from. There's also a lot of difficulties that have been faced, especially when you're trying to optimize a protocol, and there's a lot of trial and error. So importantly, menstrual blood, in the best of cases, can only be collected once a month. And that 1 to 3 days of menstruation is a pretty short window to coordinate with people in order to have them collect it and get it to us. In addition, timing of menstruation is, of course, as I'm sure many of you know, not always predictable. So it's difficult, again, to coordinate collections and then also prepare for isolations in advance. And there's also high levels of variability in menstrual blood itself. So not only between individuals, but also from cycle to cycle. And I have firsthand experience with this. The yield of cells, the consistency, the amount is very variable. And finally, just the development of a novel technique. So because there's variability in endothelial cell phenotype, it's kind of difficult to say 100% that I have endothelial cells. And of course, these cells may not express the same markers that we commonly use to study them, or to study endothelial cells. That's that.
Okay. So, questions?
Cool.
I have a lot.
Just because it occurred to me while you're presenting, Megan, that this would be a useful thing to share. Do you want to talk about your experience with trying to get known HEECs, like commercially available from a hysterectomy or endometrial biopsy?
Yeah. So obviously that's like a great place to start. I've been using HEECs usually as a positive control, which, as I've mentioned, may not necessarily represent the same phenotype that I'm looking for. So I've looked into buying commercial HEEC, but the problem is that the few places that do offer them, there's just not a lot of information about the actual sample collection. There's no information about the donor. There's no information about the time of the month, the phase in which it was isolated. There's no information if it was taken from the functional layer or the basalis, which again it's hard to know for sure if that cell type would even represent the specific vascular bed that I'm looking at. It's definitely something I want to look into more in the future, but for now, I've been trying to get more information from a few companies. But
okay. So for all of your donors, are these people that are not on any form of hormonal birth control?
So far, yes.
So far, yes.
So importantly, the exclusion criteria is non-stable use of hormonal birth control. So we say that if they've been on it consistently for 3 months, they still are eligible. I know for a fact that none of the controls that I've isolated cells from are on hormonal birth control.
Okay. And then from your known HEECs, or I don't know if any staining been done with full tissue samples, do you still see that change in the typical endothelial cell profile, where the typical markers aren't shown up in your cultured cells?
So that's a good question. In lots of studies that I've looked into that look at actual tissue sections of the endometrium, they do not have that downregulation in markers that you would see in cultured cells. And this is similar to other tissues that I've read about of the female reproductive tract. So I see a lot of studies on like decidual tissue and placenta tissue, and comparing tissue section and cultured cells, across the board, there's a pretty big downregulation of like CD31, CD34, and CD144. So while it is a commonly used marker that I think it was a good starting point, I'm looking outwards at other markers that may potentially tell me for sure what I'm working with.
Could you go back to one of your very first slides, the anatomy? I'll ask you some questions about exactly what is menstrual blood.
good. I feel like it's a lot, so I'm glad it's making some sense.
Maybe one more. You've got the picture of,
This one,
no, not further.
even further. The very first one, it must be, yeah?
Yeah. This one here. Yeah, exactly. This is it. So when you bleed, you're bleeding from what vessels?
So this is an insane process. I actually can't even, I'm so happy I'm doing this project because I had no idea. And so what happens basically is when you have that drop in progesterone towards the end of your end of the secretory phase, your blood vessels constrict. And we know this mostly from scanning electron micrograph studies of the endometrium. Basically what happens is these blood vessels constrict, and this immediate constriction limits blood supply to the tissue, and you get almost like an ischemic state. And then following that constriction, the blood vessels subsequently rupture, and that rupture is what causes the bleeding. And so when you think of that functional layer, it is completely, well, not completely, but mostly shed over the course of menstruation. But that initial bleeding is going to be from those ruptured vessels once they dilate after that constriction.
But I mean, looking at this, of course, I know nothing about this. I mean, you've got capillary endothelium, you've got venous endothelium,
Yeah.
venous legs, and you've got spiral arteries that are not far away.
Mm-hmm.
So you kind of automatically got three heterogeneous populations of endothelial cells which will look different and act differently. Is that possible?
So it is possible, which is not something I have. It's definitely something I've thought about. By and far, the vessel that is most widespread throughout the functionalis is going to be those spiral arteries, especially towards the secretory phase. The reason they're called spiral arteries is because once we get into the secretory phase, I'll show you right here. Once we get into that secretory phase, this tissue will actually stop growing, obviously. But what happens is the vessels don't. They just continue to grow until the point that they actually start to coil in on themselves because they're outgrowing the tissue that they're in. And so while there is, of course, going to be cells from veins, I think in my mind that's a very small proportion to what we see in a very, very vascularized piece of tissue of specifically arteries, those small arteries, and then the capillary plexus is still not as tortuous as those arteries.
So you also refer to these as being microvascular cells. Why? How?
It's a very good question. This is what I think keeps me up at night. This is what so first of all, HEECs, when isolated from the endometrium, traditionally are microvascular because they are from these small vessels. Based on how, that's kind of what I was thinking when I first took this project on. Am I working with microvascular endothelial cells that are similar to those isolated from tissue, or am I working with more of a blood outgrowth endothelial cell that's similar to those isolated from blood? Because you are obviously bleeding during your menstruation. And this is based on how I've seen them behave in culture, basically, and what I see in the phenotyping. So they do not have the markers that I'm used to working with when I work with endothelial colony forming cells. They don't really grow in the same way. They don't behave the same way. So because of that, I'm more inclined to believe that they are of microvascular origin, if that makes sense.
Thank you.
So apart from your own optimization, you receive your sample. How much do you think variability happens? Because assuming, like, these are just people at home, normal people just like, they have no these samples, yada, yada, yada. Not afraid. You are. So do I want to repeat that question? So do you think that it's going to maybe impacting your
Yeah. So the question then is, because the samples are collected by the participants themselves in their own homes, they are just kind of the general population. could that be affecting the quality of the samples and potentially, I'm assuming, like cellular yield and the success of the isolation in general, which is a very good point. And I have to say, over the past year, I've received like more menstrual blood samples than I know what to do with. And there's definitely variability, especially when you say like, keep it at 4 degrees Celsius until transport to the lab. I have no way of knowing whether these people do that. I'm just hoping that they do. Also, when I say that I've like played around with different buffer formulations, I've used different levels of serum in the buffer, for example, which has proven not great because I don't know how like even sterile or clean or like sanitary the conditions are when they do collect their menstrual blood. So there is variability there. And I think that with that, it just comes down to when they're enrolled, we provide the DEFA cup to them. We obviously provide the instructions to it and just outlining kind of how to collect the sample as best as possible. But I will say it is pretty, I mean, just from my own experience, I find it's apparent when there's a sample that's been well taken care of versus one that's not, I suppose.
So then, do you think for actual isolation of limitations, variability of itself, I think something like that is maybe a pathway successful for extraction?
Yeah, so that's a good question. And to that point, I think that that's where it becomes helpful to be isolating these cells from the same individual over the course of multiple cycles to kind of account for that in like different cycle variability, right? Which like I have had the opportunity to do with my controls. I've been able to get multiple menstrual blood samples at different cycles. So I think that that's a way in which we can kind of control for that difference between the cycles. And be able to better build a profile for each individual and how their cells behave, if that makes sense.
I shouldn't ask because I got a D in this exam. So, but how easy is the characterization steps for all of this? Because like, could you include like a cytospin just to quickly, check, see what cells you've got and maybe stain a few? Because it looks like you have to do quite a lot of bead separation and pads and stuff.
Yeah, so it's been tricky just with timing, right? So for me, the methods for this have to be, if I get a menstrual blood sample one morning and I don't know it, right? It's like, it's hard for me to obviously schedule an appointment to go do fax sorting, right? So a lot of times I get a text from someone saying, I have a tube for you. And it's like, go time, right? So just based on the optimization, I lean towards the magnetic activated cell sorting and things like density gradient centrifugation, because that's something we can do in our lab that day without needing like an appointment or extra like preparation, So that is a limiting factor in terms of what I do consider for potential methods, I guess.
Yeah, I was just wondering if there was an easier way. So if you can do a quick spin down, have a look on the slide. But I don't know what that would look like.
Yeah, it's hard to, because there's just a lot of contaminating cells, okay. Like no matter what. And it's not just fibroblasts, like there's tons of immune cells. I can see them when I look at them. Non-adherent cells have to be washed away within a few hours because even with red blood cell lysis, even with like histopac separation, you have a lot of red blood cell contamination, other cell contamination. So like the limitation is that these are kind of messy samples, obviously, right? So
I'm curious about what it is you expect you're going to see when you have the patient versus the controls. At one point in your slide, I think I caught that you're predicting that there will be a difference in increased proliferation. Mm-hmm. Why do you think that they will proliferate faster?
So if we go back, to the known causes of heavy menstrual bleeding, so that palm-Cohen identification system, what falls under endometrial causes is going to be local factors like vessel formation, angiogenesis, and repair. So what other studies have actually found is that women with heavy menstrual bleeding, unrelated to a bleeding disorder, they have their vessels in their endometrium are actually they grow fast and they're less like structurally sound. Basically, they're weaker vessels and they grow quicker than the normal vessels. So they have kind of altered angiogenic activity just in women with heavy menstrual bleeding compared to non. So because of that, this is an area we want to explore, especially because microvascular endothelial cells are one of the main, not one of the main, but one of the markers that they do have is that they have angiogenic behavior in things like 3D gel models. They have responsiveness to VEGF, things like that. So it seems like an avenue in which we could find answers to why these women are at higher risk of heavy menstrual bleeding.
So you have seen that in other
Yes.
Okay, so
Yeah. So what I've seen in
blood-derived.
yes, looking at just heavy menstrual bleeding and not necessarily in the context of VWD, is that they do find that there's increased fibrinolytic factors. So basically, the factors that break down clots are overactive. So you have increased clot dissolution, right? So that's been one thing that they think could be contributing to this. Other things like responsiveness to VEGF, vessel formation in general could be a cause. There's also potential inflammatory causes as well if there's some type of increased inflammation that could be causing increased heavy menstrual bleeding. So there's just a lot of things when you look at non-structural causes to be explored, basically.
Yeah, because you would expect, obviously, in the regeneration of tissue, there's going to be a lot of angiogenesis going on.
Yeah, so it's nuts. Like the functional, it's just that layer. Over the course of 10 days, this thing grows from about 2 millimeters to 8 millimeters in 10 days, and all that vasculature is formed. And so, yeah, in my mind, it's like there could be some fragile vessel formation. There could be some dysregulated angiogenic activity, I guess.
Have you been able to establish lines from any of these, either the blood-derived or these endometrial-derived? Do they immortalize?
Not that I have experienced yet anyways. I'm not at that stage for sure. I have quite the repository of cells though, so.
Do you want to talk, Megan, about the role of VWF outside of the uterus and other endothelial cells and what it does in terms of the regulation of blood vessel growth and development? That negative regulatory piece?
Yeah, so what we do see in patients with VWD, interestingly enough, when we isolate endothelial colony forming cells from, like the endothelial colony forming cells from peripheral blood of patients with VWD, and this is anecdotal, of course, but we find that we have a very high % success rate with these cells. They grow and proliferate in culture much better than any of our normal controls. And so that, lends to the some kind of, again, link potentially between this disease and the angiogenic potential of endothelial cells in general, I guess.
For your the different way you collect the blood, you say some have like heavy menstrual bleeding, some are between like the 50 and 80 ml. Is there a difference in like the cellular composition?
Sorry?
Is there like a difference in the cellular composition when you get it?
So that's a really good question. There's huge variability. So just in cellular content in general, like obviously when I'm counting them just with like a hemocytometer right off the bat, right? Like I can't really just differentiate between anything other than like red blood cells, but like we're looking at like hundreds of millions of cells, right? Like it is just nuts. Some samples are just like thick with cells, and then some I get are just like there's nothing. Like I can't get anything from them. I can't quantify anything. And of the immunophenotyping that I have done, this is obviously more so once the cells are cultured, but in the earlier days of optimization, so like beginning of last year, there was tons of variability in like different cell types. Obviously, fibroblasts were a big one, and then your endothelial cells, but there is a lot of variability in patient to patient and just from cycle to cycle for sure.
I'd like to ask about the, I guess almost like the philosophy of making a sample out of endometrial cells where it comes from the organ that has a high cellular complexity. huge temporal changes in hormonal environment. And then, if I understood you right, there's also ischemia at some point that comes in. But the way you are making these preps of these cultures there, well, you're going for a monoculture, right? And then presumably grow them in the incubator with the defined medium and defined CO2 concentration and whatnot. Losing those temporal changes, hormonal changes, levels of nutrients, whatnot, is that expected to play a role in the accumulation of VWF, its secretion, or anything of the sort?
Yes, it's a great question, and it's definitely something that, like, at this phase of my project, it's going to be like characterizing these cells, you know? And so one of the big things I want to look at is when you mention hormones, the different hormone receptors on these cells. As I mentioned before, cells in the functionalis are highly hormone sensitive. And so progesterone receptors, estrogen receptors, being able to identify if, again, the receptor expression of these cells, and maybe also even compare that between VW patients and normal controls. Interestingly, in a lot of studies, well, not a lot of studies, in some studies I've read, even just including those hormones in media of cultured HEECs, they're able to increase VWF expression. So by supplementing media with estrogen. So I actually do plan to do different experiments to see if the inclusion of different hormones in the media itself has some influence on the cell type. It's also interesting because you have to think of these cells, like the merit in what I think it is, this project is that you're able to look at the cells at that specific phase of menstruation. So you also have to think about what the environment is like at that phase of menstruation. So in terms of what hormone levels would be, what these cells may already be programmed to behave like, I guess. I don't think that they're necessarily programmed to be expelled from the body and survive, to be honest with you. So it's, yeah, there is going to be optimization in terms of how we can maintain them in culture and have them hopefully be as accurate to how they would behave in the body as possible.
Okay, we've had a nice discussion. It's 5 past the hour, so I guess we'll call it there if there are no other questions. Join me in thanking Megan for
Thank you.